Assalamualaikum warahmatullahi wabarakatuh and a good day to everyone. A warm welcome to all my friends, especially to Madam Harina Nurashikin binti Sharif. Today, our team will presenting a clinical overview of cardiac aneurysm. The aim of this presentation is to help us better understand what cardiac aneurysm is. We hope this presentation will be informative and beneficial for everyone. Before we begin, let me introduce our team members. The first one is Miss Nur Alia binti Mahmud. The second presenter is Miss Fatin Nurul Shazwina binti Muhammad Shukur. And the last team members is myself, Fatin Nuraini binti Azman. We will start our slide with the introduction, etiology, then complication. After that, imaging modalities, radiologist appearance, technical consideration, appropriate modality selection, and lastly, conclusion.
I want to present introduction of cardiovascular aneurysm. Cardiovascular aneurysm. What is aneurysm? Aneurysm are defined as a localized abnormal dilatation of a blood vessel or cardiac chamber due to weakening of the vessel wall. They most commonly involve the aorta, including the abdominal and thoracic segments, but can also affect cerebral and peripheral arteries. Clinically, aneurysms are often described as a silent threat because many patients remain asymptomatic until serious complications such as rupture, dissection, or embolization occur. These events are associated with high morbidity and mortality. Therefore, early detection and accurate assessment using medical imaging are essential for monitoring disease progression and planning timely life-saving intervention. This slide will present etiology, which is understanding the pathogenic mechanism behind cardiovascular aneurysms. The pathogenic foundation. Aneurysms of the cardiovascular circulation, particularly of the aorta, are rooted in an intricate series of pathogenic procedures that result in degradation of arterial wall properties. At the molecular level, aneurysm formation is driven by chronic inflammatory activity within the arterial wall. According to Liu et al. 2021, prolonged inflammation leads to destruction of the extracellular matrix, degeneration of smooth muscle cells, and a genetic predisposition. Together, these changes compromise the mechanical strength of the vessel wall. Atherosclerosis and structural breakdown. Atherosclerosis plays a significant role, especially in abdominal aortic aneurysms. The accumulation of inflammatory cells within atherosclerotic plaques accelerates degeneration of elastin and collagen in the arterial media. As these structural proteins break down, the vessel wall becomes less elastic and more susceptible to progressive dilatation and eventual rupture. Key molecular mechanisms. Matrix metalloproteinases (MMPs) enhance activity of MMPs plays a crucial role in extracellular matrix degradation, weakening the structural integrity of the arterial wall. Extracellular matrix (ECM) remodeling. Non-control of ECM remodeling is a key feature for the generation of aneurysms, disrupting the balance between synthesis and degradation. Matrix metalloproteinases, or MMPs, are key enzymes involved in aneurysm development, increase MMP activity promotes excessive breakdown of extracellular matrix components. At the same time, uncontrolled extracellular matrix remodeling disrupts the balance between synthesis and degradation, further weakening the arterial wall. This normal aorta versus aortic aneurysm. This diagram illustrates the difference between a normal aorta and aneurysmal aorta. In a healthy vessel, the wall layers are intact and well organized. In contrast, an aneurysmal aorta shows inflammatory infiltration, loss of smooth muscle cells, and thinning of the vessel wall, reflecting disease progression. These structural layers of the aortic wall. The three layers of a normal healthy aortic wall consist of the three layers, which is intima, media, and adventitia. It can be identified with vascular smooth muscle cells and extracellular matrix to maintain this integrity with delicacy coupled to strength. Intima is innermost layer with endothelial lining. Media is middle layer with smooth muscle cells and elastic fibers. And adventitia, outer layer with connective tissue and vasa viscerum. The media is particularly important as it contains smooth muscle cells and elastic fibers that provide strength and elasticity. Damage to this layer is a key factor in aneurysm formation. Pathological changes in aneurysms. As aneurysms progress, several pathological changes occur. These include inflammatory cell infiltration, progressive extracellular matrix degradation, apoptosis of vascular smooth muscle cells, thrombus formation within the aneurysmal sac, increased cytokine production, and oxidative stress caused by reactive oxygen species. Complications, which is understanding the dangerous consequence of aortic aneurysms. The silent treat. Aortic aneurysms are dangerous as they grow progressively and can rupture suddenly at any time. Many clinicians know that for aortic rupture patients, when life-saving surgery can save even the dying in the most critical phase, it is already too late. By Lu et al. 2021. Aortic aneurysms are often referred to as silent treats because they enlarge gradually and may rupture without warning. Many patients remain asymptomatic until a catastrophic event occurs. Even with advance in surgery, rupture is associated with very high mortality. Clinical presentation spectrum. Asymptomatic phase, which is patients with abdominal aortic aneurysm, may show no symptoms initially, making early detection challenging. Enlargement symptoms. Aneurysm growth causes abdominal or back pain as pressure increases. Rupture crisis. Hypotension and shock occur when rupture happens, requiring immediate intervention. Clinically, aneurysms present across a spectrum. In the early stage, patients are often asymptomatic as the aneurysm enlarges. Symptoms such as abdominal OPP, may develop due to pressure effects. Rupture leads to hypotension and shock, requiring immediate emergency intervention. Structural compression effects. Adjacent structure impact. Compression of adjacent structures, such as esophagus, by descending thoracic segments, leads to symptoms like hoarseness and increased risk for later dissection. Refer to Adhan Lee et al. 2025. Esophageal compression, force changes and hoarseness, increased dissection risks. Large thoracic aneurysms can compress adjacent structures. For example, compression of the esophagus may cause dysphagia, while involvement of nearby nerves can lead to hoarseness. These effects also increase the risk of dissection. Other serious complications include intraluminal thrombus, which is blood clots formed within the aneurysm cavity, creating additional risks. And second, distal embolization, which is clot fragments break off and travel distant organs. Third, ischemia and infarction, which is tissue death occurs due to blocked blood flow. And last, cardiac events. Altered aortic structure increases risk of further cardiac complications. Changes in aortic structure can also increase the risk of additional cardiac events.
There are various types of imaging modalities that can be used in diagnosing ventricular aneurysm. Imaging modalities also plays a big role in diagnosing ventricular aneurysm as well as for pre-surgical planning by clinicians. There are three primary imaging approaches that can be used in diagnosing ventricular aneurysm. Number one is the echocardiography or ECG. ECG provides real-time imaging of ventricular wall motion, and it is widely available and it is one of the non-invasive procedure. Next, for the cardiac CT provides a superior spatial resolution for detailed anatomical assessment, while in cardiac MRI, it provides an excellent soft tissue contrast without using any ionizing radiations. Echocardiography can act as the first-line tool in diagnosing ventricular aneurysm. This is because it is widely available and has the ability to capture real-time images of ventricular wall motion and help the clinician to distinguish between dyskinetic or akinetic pouching, and it is a non-invasive procedure. These advantages make it suitable for a long-term assessment as it is portable and do not use any ionizing radiation. However, ECG limited to its diagnostic accuracy on the operating scales itself, and the image quality might be poor in obese patients as they provide a poor acoustic windows. For cardiac CT have the advantages by providing a superior resolution images. Cardiac CT or CT angiography promotes superior spatial resolution in comparison to ECG. In other words, it has the ability to visualize the ventricular anatomical even at the sub-millimeters resolution. As cardiac CT provides high spatial resolution images, it provides details of aneurysm size, wall thickness, and morphology, as well as the existence of neurothrombus or calcification. And it is actually useful in surgical planning by the clinicians. So, but the consideration, it is use of ionizing radiation, so it is unsuitable for a long-term assessment. Cardiac MRI provide higher contrast soft tissue visualization in comparison to ECG and the cardiac CT. Besides, it is useful to differentiate between aneurysm and pseudoaneurysm by visualization and assessing the myocardial wall continuity. The usage of the late gadolinium enhancement in cardiac MRI helps in visualization of the myocardial fibrosis, transmural scarring, as well as chronic infarction. However, cardiac MRI have its own limitation, which is longer acquisition time. In other words, the scanning time might be longer in comparison to the cardiac CT and ECG. In addition, cardiac MRI availability is limited to all places or to only certain places of imaging modalities department, and cardiac MRI also costly. Next, I will present on radiological appearance of ventricular aneurysm in each modality of imaging. Radiologically, in ECG, a true ventricular aneurysm is characterized by a localized outward deformation or outpouching of the ventricular wall with marked thinning, or also known as dyskinetic, and either absent or abnormal systolic motion, which is akinetics. Akinetic segment shows no contraction in systolic movement due to fibrotic replacement after myocardial infarction. In ECG, aneurysm typically demonstrate paradoxical expansion during systole and diminished contractile performance when compared with adjacent myocardium. Fibrotic tissue frequently makes up the aneurysmal wall, which increase the echogenicity on ultrasound. According to Fagenbaum et al., a mural thrombus can be detected as an echogenic structure attached to the aneurysm cavity, especially when contrast-enhanced echocardiography is used. So this is an example of ECG case. As can we see here, figure 2, transthoracic ECG reveals dyskinetic ventricular outpouching and an echogenic thrombus, which can be seen in the arrow here. On parasternal long axis and 5-chamber views of left ventricular aneurysm with mural thrombus. While the appearance of ventricular aneurysm in cardiac CT, a ventricular aneurysm is seen as an outward protrusion of the ventricular walls with smooth edges and thin walls. For chronic aneurysm may show calcification, whereas mural thrombus appears as non-enhancing low-density filling defect. So, cardiac CT imaging also useful for pre-surgical planning and evaluation of aneurysm and its relationship to coronary arteries by CT. So this is an example in cardiac CT case. Figure 3 shows that cardiac CT findings of a left ventricular aneurysm. Contrast enhanced CT shows a localized bulge of the ventricular outline with thin wall and certain features accompany thrombus or calcification in this area of the arrows. So, cardiac MRI visualization of the ventricular aneurysm, it might represent a specific outpouching that display reduced to absent contraction with continued connection of the myocardial wall. While for thrombus, it might appear in cardiac MRI as a non-enhancing mass, and it helps to distinguish between true aneurysm and pseudoaneurysm by using late gadolinium enhancement. Okay, this is a figure 4 showing a left ventricular aneurysm with a broad neck bulge on the inferobasal wall is visible on the cardiac MRI. Sign imaging demonstrate an irregular pattern of wall motion, and late gadolinium enhancement highlights transmural scarring with thrombus. For summary, ECG offer excellent functional assessment but restricted in terms of anatomical details. While in CT cardiac, it is beneficial for anatomical appreciation, and it is also helpful for a clinician for pre-surgical planning. Lastly, cardiac MRI help to distinguish between aneurysm and pseudoaneurysms. It also provides a high contrast soft tissue visualization.
Good day, everyone. My name is Fatin Noini binti Azman, and I will be presenting the technical consideration in the imaging of cardiac aneurysm. In this section, I will be briefly explain the important The technical factors involved in echocardiography, cardiac CT, and cardiac MRI that influence accurate diagnosis and clinical decision making. For technical considerations, echocardiography is usually the first-line imaging modality because it is not invasive and provides real-time assessment of ventricular wall motion. However, its accuracy is highly operator-dependent. Image quality can also be affected by poor acoustic window due to patient body habitus or lung interference. Despite this, echocardiography is very useful differentiating between dyskinetic and akinetic ventricular aneurysm. Then, technical consideration for cardiac CT. Cardiac CT offer superior spatial resolution compared to echocardiography. From a technical perspective, it allows accurate measurement of aneurysm size, wall thickness, and morphology. It is also excellent for detecting mural thrombus and calcification. However, it requires ionizing radiation and iodinated contrast, which must be considered, especially in patients with renal impairment. Cardiac MRI provides excellent soft tissue contrast without radiation exposure. Technically, late gadolinium enhancement helps identify myocardial scarring and fibrosis, while wall continuity assessment allows differentiation between true aneurysm and pseudoaneurysm. The main limitation is the longer acquisition time, which may not be suitable for unstable patients. Now we will move on to the next slide, which focuses on appropriating imaging modalities for cardiac aneurysm. In this section, I will discuss how different imaging techniques are selected based on their diagnostic strength, clinical indication, and patient condition. Choosing the most suitable imaging modality is important to ensure accurate diagnosis, effective treatment, planning, and optimal patient management. For appropriate imaging selection, a multimodality image approach is recommended to achieve the most accurate diagnosis of cardiac aneurysms. Echocardiography is ideal for initial screening and routine follow-up because it is widely available, non-invasive, and provides real-time assessment of ventricular wall motion. Cardiac CT is preferred for detailed anatomical evaluation as it offers high spatial resolution that allow precise assessment of aneurysm size, wall thickness, and associated complications, making it especially useful for pre-surgical planning. Meanwhile, cardiac MRI is most suitable for tissue characterization, scar and fibrosis assessment, and for different the between true aneurysm and pseudoaneurysm without the use of ionizing radiation. By combining the strength of these imaging modalities, clinician can obtain a more comprehensive and reliable evaluation, leading to better clinical decision making and patient outcomes. In conclusion, cardiac aneurysms are serious and potentially life-threatening conditions that often remain silent until complications occur. Early detection and accurate assessment are crucial for effective management. Imaging plays a central role in diagnosis, monitoring, and treatment planning. A multimodality imaging strategy using echocardiography, cardiac CT, and cardiac MRI provides the most comprehensive evaluation and supports optimal patient outcomes. We would like to express our sincere gratitude to our lecturer for giving us the opportunity to present this topic. We truly appreciate the guidance, support, and valuable feedback provided throughout the completion of this assignment. We hope that this presentation will be beneficial and provide meaningful insights to all.